oncology. I'll try to summarize the highlights in GI cancer. I'll go from top to bottom. I'll start with the TAX study. This is a phase 3 randomized controlled trial, double-blinded in heavily pretreated patients with advanced gastric cancer and G-junction cancer. All patients had at least 2 prior treatment lines. More than 60% had 3 or more prior treatment lines. 507 patients were randomized 2-to-1 to TAS 102 plus best supportive care versus placebo plus best supportive care. Primary endpoint overall survival was significantly better in the TAS group, and the PFS as a secondary endpoint was significantly well. Hence, TAS 102 is an active drug, not just in metastatic colorectal cancer patients, which we know from previous randomized controlled trials, but also in gastric cancer patients. The next study is, which is interesting, is the phase 1b trial in HCC patients. This is a cohort of 103 patients, frontline atezolizumab 1,200 milligrams every 3 weeks, plus bevacizumab 15 milligrams per kilogram body weight every 3 weeks. In this cohort, 50% of all patients had hepatitis B, 30% had hepatitis C, and 20% had no viral hepatitis. Objective response rate was very high, 32%, and disease control rate as well, very, very good, 77%. Patients who did respond often had durable responses. Median PFS is 14 months, which is unheard of in HCC patients, which is a prognostically poor entity. And the FDA, based on these data, has granted accelerated approval for frontline treatment of HCC patients with atezolizumab and bevacizumab, and there is an ongoing phase 3 randomized controlled trial with ate-beva in comparison with the current standard sorafenib. Trial, which was interesting, was presented by Heinz-Josef Lenz, was the long-term data of Checkmate 142. This is a relatively small cohort of 44 patients with mismatch repair deficient metastatic colorectal cancer, and patients with nivolumab standard dose 3 milligrams per kilogram body weight every 14 days. Plenty of all patients did have a complete remission, and this is interesting, responses were independent of PDL status, of BRAF or KRAS mutation. Median overall survival is not yet reached, and median duration of response is not yet reached either. Median time to response was 2.6 months, hence patients do respond, usually respond within the first 3 to 4 months of treatment. Now, severe adverse events were only 16% of all patients, and this is very similar to nivolumab monotherapy. Hence, the added toxicity of low-dose ipilimumab is very minimal. Conclusion of this study: nivolumab and low-dose ipilimumab is a new treatment option in patients with mismatch repair deficient metastatic colorectal cancer. And last but not least, a small trial in anal cancer patients. This is a phase 2 multi-center trial in patients with metastatic squamous anal cell cancer. 91 patients were 1-to-1 randomized to the standard cisplatin 5-FU versus carboplatin and paclitaxel, and objective response rates were similar, 59 and 57%, so no difference there. However, overall survival was significantly better in the group with carboplatin and paclitaxel versus 12 months, so a clinically very relevant difference in overall survival. 60%, 7% of all patients did have a remission, and this is interesting, responses were independent of